Cool. Recording now. All right, everyone. So welcome to yet another exciting night, morning, wherever you are in the world, of the future of healthcare. Tonight we have a very special speaker, Stelle Smith, who I've known over a decade now. I don't know exactly when we met, but I think it was probably around 2004, if I had to guess. But Stelle has been involved in healthcare and technology um, longer than I have been involved in healthcare and technology. And he's currently based right now in New York City, so he's lecturing to us right out here from the East Coast. He has just a lot of experience in all kinds of aspects of healthcare, specifically in EMR. He has a lot of experience working with providers. And tonight, he's going to share with you some of his adventures and knowledge. And the only thing I asked Stella is, remember that a lot of these are undergrads, so they probably don't know a lot of the jargon or even some of the more commonly understood um, preconceptions or notions. I think everyone does understand that the healthcare definitely is long overdue, and I think 2020 has definitely hammered this point, long overdue for a major retrofit. So yes, I think with that, Stella, shall I hand it over to you?
Yeah. Okay. No worries. You can hear me okay, and I sound all right. Am I any reverb or we're all right?
Great on my end.
Okay. Yeah. Thank you very much, friends. We have known each other for a very long time. Again, my background, just to give you an idea, I am on the East Coast, but I have been in health. First of all, my father was a practicing OBGYN. He just retired about 3 years ago. My mother was a nurse. My grandmother was a nurse. I was basically raised in an emergency room. Right? So I've been in a healthcare environment one way or another. I actually went to medical school and left the medical school program and went into the master's. I got a master's of health administration, also public health as well, master's of public health from Medical College of Virginia in Richmond, Virginia, and worked my way through as a medical biller, first for my dad's practice and then for hospitals. So I understood both the business side as well as the clinical. And I actually wound up beating up the medical manager reps that came in. They were trying to sell a practice management solution. When I say practice management, in a physician's practice, and again, I'm going to try to go easy on the jargon, although you can easily get lost in jargon and not know what I'm talking. So just let me know, raise your hand if you don't know what I'm talking about. And if I'm going too fast, I apologize. I am outside of New York City, so I do talk really fast. So let me apologize in advance. But again, as far as my background, working in the healthcare field, I understand both when I say RCM or revenue cycle management, that's the financial aspect of healthcare, as well as the clinical aspect or workflow of healthcare. And when we talk about healthcare in the United, actually anywhere, but let's make it specific to the United States, there are really three locations or types of physicians. You have an outpatient setting, you have an inpatient setting, and you have a skilled nursing setting, right? So, and when I mean skilled nursing or inpatient, outpatient, that could be, when I talk about doctors who are outpatient doctors, that's your local doctor who might be a primary care physician or a pediatrician or internal medicine. And then you have hospital doctors who work just like surgeons typically work in the hospital. And then you have other doctors who work in nursing homes. That's when I say skilled nursing. So each one of those care settings, understanding the rules and regulations for those organizations, that's essentially what my entire career has been around. Also, when I beat up these medical manager folks, they wound up hiring me. They actually offered me a job the following day, and they said, hey, you really understood. You put us through our paces. And I worked at it was actually WebMD, and WebMD is now Greenway Health, if you go through all the iterations. And when I say Greenway Health, they offer both an electronic medical record or a clinical system, as well as a practice management system or revenue cycle management system, which is the financial aspect. And actually, let me share my screen for a second. Here, let me see if I can do this easily. Hang on. I'm gonna do desktop one. Here we go. And let's go here. Hang on. Let's see. All right. So if I take a look at this, let me see if I can start here. I don't know if you can hear. Let's play it. Oops, boy. All right, future healthcare, who cares? Okay, that's me with my bow tie. You can't be mean to somebody in a bow tie. I actually learned that at Medical College of Virginia. This is my rehab medicine bow tie. It actually has pink elephants with martini glasses. And I wore bow ties because I actually, this will age me, I had a Jerry Garcia tie. It was a long tie. And I went to my first gross anatomy class, leaned over the tank in gross anatomy, and the edge of the Jerry Garcia tie dipped into formaldehyde and ruined the tie. And this Jerry Garcia tie was the most expensive thing I owned at the time. And my professor told me, if you wear bow ties, two things. You can never be mean to somebody's face if they're wearing a bow tie, and that will never happen to you again. So actually, that's why I wear bow ties, and it's true. Actually, since that time, Francis knows when I'm at home, so I don't wear bow ties around the house. But he's known me, and every time I present, I typically have a specialty specific bow tie. And again, this is about me and blah blah blah. Who cares? This is, so I'm gonna, and by the way, are we okay? Have I numbed everybody to sleep with detail, or we're all right so far? Okay, thumbs up on that. So this is as simple as I can make it. And the reality is this might seem a little cynical, but actually, if Francis, what is the definition of all this stuff that you're studying when you say healthcare, or if you want to be a doctor, or if you want to get involved and do anything in healthcare? If I boil it down in a crucible and get to what is the point, and again, taking away the altruistic side and helping people and making people better, who cares? That doesn't, the purpose of all of this crap, of the billions or trillions of dollars that are spent on healthcare, is this sentence on the screen, which is healthcare basically combines procedures and diagnoses in a way that maximizes the amount of money that comes into a practice. That's it. When I say that's it, that's it. And if you can't see that statement in a straight line, what the hell are you doing? It is a waste of time. Francis, am I saying anything that you disagree with? I mean, you're a doctor. Okay. So, and honestly, now again, as with most things that you've probably learned already, the devil's in the details, right? I can spend now that I've told you this and we've boiled it down to a crucible, the rest of your life could be spent with the nuance and understanding the difficulties or the little exceptions to the rule. But honestly, my best advice, no matter what you do, whether you become a data scientist and do regression analysis or, survivorship bias analyses, whatever it is, a mathematician, or biostatistics, bioinformatics, biosurveillance, if you want to do that, keep this sentence in mind, because the entire point or the purpose always comes back to this. What was the procedure? What did you do? And why did you do it? And if you can't figure that out, regardless of the layers that you add on to whatever it is that you're doing, that's really where the problems come in. And actually, when Francis and I met and we went to this conference, this Health 2.0 conference, it was James Matthews, Francis and I, and we would watch these innovative healthcare companies who would present these really cool solutions. And we would all look at each other and we would say, who's paying for this? It was this really great, amazing tool that figured out how people felt. I'll never forget it. It looked at their text messaging in live real time. Remember this, Francis? And it actually, what it did is it guessed their mood. And it told you whether they were in a good mood or a bad mood based on the syntax and the way that they texted by time of day. Brilliant. A lot of interesting information, but who's going to pay for that, right? So again, combining procedure codes and diagnosis codes to maximize reimbursement. So every portion of that sentence means something. And that's what we all did, is we looked at it, we said, gee, and if you can see that, if you can say, okay, it maximizes reimbursement, it does this, it made sense and it would click and it would do so. Does that, does that ring true, or does anybody want to challenge me on that, or is that? I mean, I hate to ask, but
I have a question. So when you say reimbursement, does that mean specifically with insurance in the picture, or does that reimbursement even like reinvestment or return on investment? Is that also what it's covered by reimbursement?
I didn't mean it only to be insurance. I meant it to be any type of reimbursement. I mean, the reality is that it's about getting money in, right? So, and I can expand this to a hospital if I'm doing a capitation program, or I'm doing, when I say capitation, or a staff model HMO. Here, I'm saying something and you have no idea what the hell I'm talking about. So, Kaiser, anybody who knows Kaiser on the West Coast, they are the best example of something called a staff model HMO. Basically, what a staff model HMO is everything is underneath one roof. When you go into Kaiser, you go into the emergency room at Kaiser, you see your primary care physician. It is a single source for all of your healthcare needs, regardless of care setting, regardless of specialty, regardless of lab, pharmacy. Everything is done underneath one roof. And it's very hard to do that. It's really, in the American healthcare system, getting reimbursement, or getting the way that our insurance is set up, or the way that we pay for things with elective procedures or non-elective. When I say elective procedures, things that don't have to be done, right? If you need plastic surgery and you want to have a nose job or an eye lift or blepharoplasty, whatever it is, that's not a necessary procedure unless there are certain reasons why it would be. But most of the time, you'd pay for that out of pocket. That's a very different thing than if you have an acute gallbladder attack and you need your gallbladder taken out. So I mean it to be more, when I say reimbursement, more than just that one. Does that make sense? Okay. I'm going to keep going. And again, any other questions so far? Because again, I don't want to talk the entire 2 hours, because you guys are probably already checking your emails now. So is there anything you want to ask, or anything not clear, or anybody want to challenge? And it's okay if you don't. I'll wait a few seconds.
Any questions for anybody?
Perfect. Okay, I'm going to keep going. So again, this is just when I say some of the terms, right? So healthcare reimbursement, each one of these bullets around the side is an example of a technology or something that happens in the healthcare system. So the one on top, CPT and ICD. CPT stands for current procedural terminology, and that refers to the procedures. So in other words, what did you do? And this is when we say doctors are reimbursed. And again, let me talk about a specific type of doctor. Let's talk about a family practice doctor who sees patients coming in a primary capacity. What I mean by that is, when you get sick and you go and see your doctor, your family doctor, that is typically the first, when you go and see a general practitioner in an outpatient environment. That's your doctor down the street. The way that they get paid typically. Oh, and did we finish the staff model HMO? I'm sorry, I don't think we did. Let me back up for a second on that. Staff model HMO basically is everything underneath one roof, and it's all one system. So the laboratory, the specialists, the hospital, the nursing home, the outpatient, all of those doctors all participate in one system that communicates as seamlessly as you can across those departments and types of practices of medicine. That's different in every place else in the United States. Kaiser is the only. I hate saying the only, but it's the only one of significance that exists still in the United States. And what we found is that staff model HMO, when you keep everything underneath one roof and you have control over it, yes, your care might be slowed down a little bit, but actually outcomes or treating people, if you look at heart disease, the big things that are hard to treat, chronic diseases like diabetes, type 2 diabetes, or heart disease, or cancers, or anything like that. Heart disease, as an example, if you look at Kaiser's outcome numbers, when I say outcomes, how do patients do? If I have look at me, look at the size of me. I have high blood pressure because I eat like an 8-year-old. I eat like a toddler all the time. So because of my diet and my weight, I have high blood pressure, hypertension, a couple other issues, probably pre-diabetic, if not diabetic. Those of you saw I'm drinking a Mexican Coke here to keep me awake because it is 9 o'clock at night and I'm getting old. So again, I have all these issues, my blood pressure. If I were at Kaiser, the outcome of my hypertension and my heart disease, I'm going to do much better at Kaiser because my cardiologist who treats my heart talks to my internal medicine doctor, who talks to my spinal surgeon who did my fusion surgery, who also talks to my hip surgeon who did my hip replacement, who also talks to my gastroenterologist. So they all talk to one another and share a single electronic medical record and share one common record. So my medications and my outcome or my heart disease gets treated in a way where my outcome or how likely I am to die of a heart attack or hypertension or anything else is dramatically reduced because of that staff model HMO, because Kaiser would be one of the places where I'm treated all underneath one roof versus where I live and actually I do have access to Kaiser because half the year I live in Los Angeles. I live in a town called Woodland Hills. The other half I live in Asbury Park, New Jersey, which is outside of New York. But outside of the West Coast, outside of Kaiser, everybody else, typically, all those doctors I mentioned, my internal medicine doctor, my gastroenterologist, my cardiologist, my nephrologist, each one of these doctors, different, doesn't matter what kinds of doctors they are. I have an insurance, I have Cigna Healthcare, and Cigna pays each one of those doctors, but each one of those doctors is an independent entity. So the primary care doctor that I see, she's a concierge doctor. I think she owes Jesus some money for playing basketball with him. She's really old, but I pay her some money and she treats as a gatekeeper. She does all my meds and all that stuff. She doesn't have an electronic medical record. She still uses paper records. Then my cardiologist uses Intergy. It was a system that I sold them 30 years ago or 20 years ago. Then my gastroenterologist uses eClinicalWorks. Those systems that I just mentioned are different electronic medical records, each written by a different set of programmers, each with a different programming language, none of which communicate with one another easily. So as a result, unless my primary care doctor takes it upon herself to call my other doctors and talk to them, care coordination, while it's still possible, the outcome for somebody like me on the East Coast, it's a lot harder to treat common chronic disease. When I say chronic disease, I mean diseases that last more than 3 months. By the way, difference between an acute disease process and a chronic disease process, very simple. It's basically 3 months versus 6 months, right? So acute, something that's new, brand new, instant, you have access to it right, or you have an onset right away, and it usually resolves fairly quickly. Chronic disease is something that you've had over a period of time. So, and the chronic diseases that you would see, whether it's treated at Kaiser in a staff model or any place else, those are the ones that you're always hearing about, other than COVID. Let's leave COVID to the side. But diabetes, colon cancer, breast cancer, hypertension, heart disease, all of the asthma is another one. These are common core chronic diseases that everybody treats, and everybody treats slightly differently. And those slight differences, plus having to communicate between different healthcare settings and different doctors using different electronic medical records, some of them not using electronic medical records, makes it very, very difficult for information to flow as easily as somebody like Kaiser that has this staff model HMO where they're all using the same system, whether you like it or not. When you go to Kaiser as a physician or as a nurse practitioner, if I'm an anesthesiologist, a cardiologist, internal medicine, nephro, doesn't matter, you use Kaiser's electronic medical record in their revenue cycle management system, whether you like it or not. And it's, while it's harder to learn initially, it's better on the back end there, because we've seen over time, Kaiser has proven over and over and over again, if you look at their results, that's what's called an outcome. Their outcomes for diseases are better. And we have ways of measuring that. And that's what you guys are doing, this future of healthcare, is all about where do you want to fit in this. And this is a simple, this drawing that I have up on the screen with CPT and NDC. So let me go back to this. And by the way, does that make sense? Or does anybody have any question when I said, yeah, Francis, go ahead.
A quick question. So are you saying that Kaiser is the closest thing we have, at least to scale, the staff HMO system? Is that the closest thing we have to a single payer system that other countries basically exercise?
I would say so. I mean, you can educate me if you know of a different one. I mean, there are others that come close, but I think Kaiser is as close to the ideal of a single payer system. When we say a single payer system, you think of Germany, you think of the UK, right? So, and again, you may have Korea. I know we have somebody who's from Korea.
We have a Canadian too.
What's that?
We have a Canadian here too.
Oh my God, Canada. So yeah, perfect. And well, Canada, there's different provinces and they treat differently based on provinces. And then in Montreal, the province where Montreal is, everything has to be in French. So please, let's not talk about Canada. But yeah, to answer your question, I think that, yes, I believe that in the United States, the closest thing to a single payer system or analog to a single payer system would be the Kaiser model, right? But if you look at the UK, NHS or CPRD, right? So if you look in the NHS, the healthcare system in the UK, it is single payer. It is, you'll hear socialized medicine. When we say single payer, it basically means that everything goes through one system, right? So it all gets put into the same system. And the benefit of that is you don't have to translate between location and location and type of electronic medical record to another type. I mean, and does that answer your question, Francis, or do you agree with that or disagree with that? Okay.
Agree. Yeah, absolutely.
So yeah, and I mean, let's talk about that. Okay, first of all, if I'm in an outpatient environment, if I see my doctor, okay, let's use me as an example, okay? When I broke my hip, I have a hip, I have a metal hip because I used to be a roller derby rep for women's roller derby in Los Angeles and all over. And I got my hip broken, I guess, in 2015, and it was smashed. I got into an accident, so they actually had to replace my hip. I initially, where I went to the hospital and they took an X-ray and they took all my medication. Now, first of all, they had to get my medications that I was on. I was on lisinopril, I was on hydrochlorothiazide. These are medications, blood pressure medications. I was on Singulair because I had an upper respiratory thing, and so let's just use those three medications. So I go into the hospital with my shattered hip. They had to take a picture of my hip. They had to get my medications. I told them verbally what my medications were. So they wrote that. Actually, this was in Chicago where I was injured. And I was in Chicago, so I was actually at Northwestern. They took an X-ray. They verbally took the medications from me. They put it into their healthcare system, which was Epic. Actually, excuse me, it was Cerner at the time. So when they entered my medications, they used something called RX norm, which is a way. So you see this NDC code over here. NDC is one way that you would indicate drugs, the name of a drug. Another way to indicate a drug in electronic medical records is to use RX norm. So it's a different method. It essentially means, so if I have that, let's use one drug, lisinopril, I have a code that's an RX norm code for lisinopril, and I have an NDC code for lisinopril, and they're two completely different codes with two completely different hierarchies that essentially mean the same thing. So when I got this record that was a hospital record from Cerner that had RX norm codes, it also used the billing form called a UB form, which is a UB92, which is what you would use to bill for a hospital, because I was at the hospital. So they did an X-ray, they did an evaluation and management, they did a medication review, and then they sent me back from Chicago on a train because I couldn't fly. I had to go back on a train back to the East Coast, and I saw my primary care physician, who at the time did have an electronic medical record. This was before I found concierge medicine, before concierge medicine existed. It existed, but I wasn't paying for it at the time. But then what they had to do is take that electronic record from Northwestern University. They were able to view the PACS image, or when I say PACS, they were able to view the electronic image of my broken hip and verify that it was broken. But then they had to take that RX norm code that indicated lisinopril, and they had to map that to the NDC code for eClinical Works that my primary care physician used. So electronically, I had to communicate between the two systems that don't talk to one another, one in Chicago, one in New Jersey, and I had to send an electronic file that was RX norm to something that was an NDC code in a system that didn't talk to one another. And then from there, I had to go see another physician for my hip who wasn't using eClinical Works. They were actually using Medical Manager. So now eClinical Works had to use their back end where they translated my lisinopril medication and added oxycodone and a couple other things for pain and blah, blah, blah. And also they had to translate those NDC codes into the, it was NextGen. So it had to communicate from eClinical Works using their proprietary backend, but these NDC codes, they had to communicate with something called the KBM, which was a proprietary tool that NextGen wrote that actually said lisinopril, which could be an RX norm code or an NDC code, as well as the oxycodone and the other stuff that they had to give me. So again, I had to communicate with different healthcare systems and different doctors' offices who had different electronic medical records. And each time I would go in, I'd have to fill out my paperwork with my demographic information. I'd have to put in my name, my address, my insurance information, and I would send that over from the primary care to the hospital. I'd use it at the hospital. I would use it back at my primary care doctor. I would then use it at the specialist. Then I would have to go to another specialist, and I have to go to a different specialist. So each specialist that I went to, I had to do that same, where I'd fill out manually the information. I would fill that stuff out, and then they would send the information electronically from one place to another. And they couldn't do it. In 2015, you didn't have, it wasn't very easy to send that lisinopril. Well, let's use one drug, lisinopril, to send it from RX norm in Epic or Cerner to eClinical Works NDC code. That was difficult enough because it wasn't part of the same network, wasn't the same system, wasn't the same output, because actually it was a UB form for the procedures that were performed. But then back in my hometown, when I went to see an outpatient doctor, they then switched over to something called the HCFA 1500 form, which was a completely different billing form. So from a billing perspective, again, I'm speaking in two totally different languages from Chicago to New Jersey. And then in New Jersey, I would speak to one doctor, and whatever I did at one doctor, going to the next doctor, I had to completely reinvent that from scratch. And then they couldn't send that NDC code from eClinical Works to NextGen. So the easiest thing to do was just to send a PDF or a Word document, essentially a text document of my medical record that you would have to read to figure out what was in it. And a clinician, a nurse or a doctor, would have to read this piece of paper, this PDF, and say, lisinopril, let me find that in my system. Oh, oxycodone, let me find that in my system. And they would have to manually go through and read this record and extract that information to make it transferable from one place to another. That's important, right? Because when we talk about the future of health, like, again, we can go, and I can spend 2 hours just on this, right? Because I haven't even talked about, let's say after I had my hip replacement, I have steps in my house. I live in a 2-story house on the Jersey Shore. So I couldn't walk up my stairs. I live alone, right? So I couldn't go home. I had to go to a skilled nursing facility after my hip replacement for 2 weeks so that I could do occupational and physical therapy. So that, remember I said the UB92 was Northwestern, the HCFA 1500 was my doctors in an outpatient environment. Then I was back to a UB92 when I had my operation at the hospital. Then when I got kicked out and put into a step-down unit, I went to a skilled nursing facility and I had to use something called an OASIS form, which was totally different. And that didn't communicate with the electronic medical record from the outpatient environment, which didn't communicate with Cerner. And then, God forbid, I had to go to another hospital that uses Epic. Epic doesn't talk to anybody. So it's really, that's the state of healthcare. Even today, as we look today, that is still where we're at. We really are having all these differences. Now, it's gotten better, even though I'm saying it's really disconnected. In 2020, 2021, we have some standards. Each one of these standards, there are tools and there are maps between CPT. First of all, CPT and ICD, I mean, we could spend 3 hours on that, right? So ICD, CPT is procedures. ICD is International Classification of Diseases. There's 2 chapters. One they use is for diagnosis, one they use is for procedures in a hospital. Let's just stick with the diagnosis. As of 2015, when my hip broke in April, they used an ICD-9 code in April, which had, 6 digits, whatever it was. After October 30th, they switched over to ICD-10, which was completely different. It has no like if I were to tell you that ICD-9 type 2 diabetes was 250.00, that was the ICD-9 code for diabetes. In ICD-10, 250.00 is now E11 dot whatever 892. E11 makes no sense at all. And now, if I have diabetic neuropathy, so it would go from a couple of codes that would indicate diabetes, whatever. But now, high granularity, my left hip was the one that was replaced. Prior to October, if you looked at my claim forms, you wouldn't be able to tell that. You would look at my claim form and it would show broken hip replacement, but you wouldn't know which one. After, you'd have to read the piece. This is important. Take this down for later. Don't take it down. But I would have to read the record and I would say, oh, left hip. So I'd have to read in my attached document, and it would say, oh, it was his left hip, not his right. It was left hip, and it was the first time he was seen, blah, blah, blah. After October, ICD-10, now it would put in a code like R82.0 was the right hip, .1 was the left hip. So now you have more granularity. But the codes went from a list this big to a list this big, right? So some specialties, it became impossible. It's very difficult. People are still struggling with that simple conversion just of this top circle from ICD-9 to ICD-10. Getting those, just that alone, was very, very complicated. And it still is something people are struggling with today. But that's important. Yeah, go ahead.
Oh, sorry. May I ask you something? Is there a reason why these different systems that you went to, I don't know if they were in the same state or same even county, like the nursing home and the your primary care physician? Are they?
Are they in the same state? That's a great question. There are 2 types of questions. There are good questions and great questions. Great questions are one you have an answer for. Good questions, that's a good question. You have another question. Oh, that's a great question. So the reality is they were in different places, but that doesn't even matter. That's a great question because that's intuitive. You're like, oh, it's probably just because one was in Chicago, one was in New Jersey. That's actually not true. So even today, even if I have let's use one system. Let's use eClinicalWorks. So if I put eClinicalWorks at let's make it as ridiculously simple as I can. I have eClinicalWorks and I've put it into orthopedic specialists of the Atlantic Shore. That's one orthopedic group around here. Then I put eClinicalWorks, the same system, eClinicalWorks, into Seaview Orthopedics, their competitor. So I've put the exact same electronic medical record and revenue cycle management system in Seaview Ortho and Atlantic Coast Orthopedics. The exact same, and they are within 15 feet of one another, okay, physically. The brick and mortar building, one's here, one's there. One typically does, but again, same types of doctors, same specialty, same EMR. They can't communicate with one another. So I know it sounds dumb and you're like, that's ridiculous. It is. And this is the reality of why Francis and I have been employed as long as we have, and why this is even today with the same system in the same location, in the same communications ladder, you still don't have seamless communication between like systems, let alone systems that are from different care settings.
I'll even go one step further. I've even seen this where the same exact electronic medical record company would install the same electronic medical record in the same doctors who has two different offices, and they still can't talk to each other.
I would agree. Yes. I mean, it seems ridiculous. I mean, I'm sorry. I know that's not the answer that you want, and you're probably like, that's ridiculous. It is ridiculous. It is completely bananas. And that they and even though they really can't seamlessly do it and can't seamlessly communicate, we've come a long way. There are methods and rules and regulations that are making it a little bit better. There's something called the blue button technology, which is how you download your electronic medical record. There was something when Francis and I met, this is what I did, is I presented, there was something called a CCD, a continuity of care document that replaced something called a continuity of care record. And without getting into too much detail, the continuity of care record, they're both XML based. They're XML, XML technology. The continuity of care record was a single document. It was essentially a half step above a PDF. So instead of a PDF portable document file where you can just read everything that's in there, the CCR, or continuity of care record, had XML tags throughout the entire document. The CCD, when Francis and I met and started working together, was when they migrated into sections. So what this essentially meant, I'm telling you, and I'm not explaining it to you, with a continuity of care record that had an entire piece of paper that was all XML based, let's say I made a change to one element. Let's say I didn't want you to know that I was crazy, that you didn't know, okay? So I get my continuity of care record, and I say, oh shit, it says I'm bipolar in here. I don't want you to see that. So I delete that bipolar record before I send it on to Francis, who's gonna see me for whatever, because he's my orthopedic surgeon, whatever it was. The second that I delete that record in the continuity of care record document, the entire document was nullified. It basically meant the entire document threw it away, okay? CCD essentially was the next evolution of that, which is where we are today, right? By the way, is CCD was a section. So if I invalidated the section of a problem list where I took out my bipolar because I didn't want you to know, and it took out my bipolar, it would just invalidate the problem section, but all the rest of the sections, like the history of present illness, the operative notes, whatever, they all remained valid. So that simple change, again, that's, and incrementally, I mean, you're like, ah, geez, it seems like a really low bar. It is a really low bar, but the reality is just going from throwing away the whole record to just throwing away a section, that's where we are today. And then there's different flavors of continuity of care documents where, again, I can, like an emergency room generates one, a skilled nursing facility generates another, but having this continuity of care document, it's made it a lot easier for EMR, electronic medical record A, to send information to electronic medical record B. Now, technologically, I can share. So each one of these bubbles here would be a section of the note, a CCD section of the note. So I can send NDC over to another system that also uses NDC. And because it's continuity of care document, in theory, from a technological perspective, I could share the data. Politically, I need to make a decision as to which record is right. Is the record, well, and you say, oh, it's very easy. It's very easy if the person who's managing the record is competent, right? And the assumption right now is that the patient is the most competent person to handle their electronic medical record. You can probably tell I'm a little old. I come from the time, Francis, when he practiced medicine, He came from a time, and I came from a time, where if a doctor were to hand you a bunch of paper clips and say, take these 3 times a day, you'd probably do it. No questions. Okay, sure, no problem. Now you may ask, and you may say, oh, I want to know, why am I swallowing paper clips, whatever it is. But really, patients are the worst person, the worst caretaker of their electronic medical records. Think about it. Okay, if you're looking, there is a lot of clinical relevance in knowing that I'm not really bipolar, but if I were bipolar, or if I have mental illness, if I have some kind of mental illness, that's important information, right? But if I see that, and if I have control over it, and I need to share it with somebody, I'm probably going to be embarrassed by that and say, I don't want to share that. And you, as the patient, have a right to do that. But can I make good clinical decisions if I don't know the whole picture? You can't. The reality is, people will die from not knowing all the information. And I know that's ridiculous and everything else, but I'll tell you, anybody who's going to become a doctor, any one of you who goes into medicine, I'll tell you why I got out. I talked to my dad about this, and he said every doctor, whether they're a dermatologist, whatever they are, they will be able to tell you the person's name. Even if they're 80 years old, they'll be able to go back and tell you the person's name, who they either killed or may have killed in the past by a mistake or something that they did, even if it was 70 years ago. Think about that. I mean, really think about that. I mean, most jobs that you have, if you make a mistake, you ruin somebody's lunch order, or, oh, my coffee's bad, my morning's bad. But think about taking the responsibility on for that, of actually, gee, if I had only done this differently, that person might not have died. I mean, that's a pretty big cross to bear. And every doctor, everyone will be able to tell you, if they're being honest with you, will be able to tell you who that patient is. And it haunts them, right? I mean, I don't have to ask Francis. I know, because I was there. And I mean, even as a medical student, I remember there were a couple of things I would say, and I hadn't considered the big picture, whatever it was. And, oh, well, if we did that, this is what would happen, blah, blah, blah. Again, not to bring it down and bring this class to a catastrophic halt, but the reality is we're playing in the big leagues here. And clinical decision making, it's important to know the whole picture, and holding things back when you're considering who's best responsible for taking care. And that's why when we looked even 10 years ago, there was something, and I'm going to throw a term out at you, called the patient-centered medical home. Okay, still being kicked around today. Patient-centered medical home was a pretty good concept that essentially patient-centered medical home says, let's put the primary care physicians at the center. So if you change this up and changes from healthcare reimbursement, if you put patient-centered medical home, basically the primary care physician would be a quarterback, and they would basically monitor all of your electronic medical records, and they would be the gatekeeper of sending your information to different specialists. That actually clinically makes a lot of sense. The problem is that primary care physicians aren't really very well compensated to do that. And it's very difficult to do that properly and well. It's not scalable. It's not something that you can really scale. And that's really, so if I were to say, what is the big points that I want you to understand about future of healthcare? Because we haven't even talked about some of the things that are really future state, but future state, the thing that stands in the way, in my opinion, again, take my opinion, throw it out the window, who cares what I think? But I think that the issue that we see in not being able to adopt things quicker and in a more robust manner has to do with scalability. So I can't very easily make information flow from one place to another. Even if I have a continuity of care document, whatever it is, there are too many exceptions to the rule and when stuff happens, and something called a federated search versus a non-federated search, which basically when you say federated search versus non-federated search, it means, where does that record reside? Does your record reside in one place and everybody gets the copy from the same place? Or does it reside everywhere and whoever has the latest one, that's what a non-federated, or basically a federated is all one place. Non-federated means it's all over the place. And that's really where we are today, is these non-federated searches, these non-federated electronic medical records, Well, which one is accurate? That becomes a lot more difficult to answer. And the reality is that no human being, whether it's patient-centered medical home and then with patient-centered medical home, it got into cardiologists started to bitch and complain and say, oh, primary care doctors don't know enough about hypertension to treat it properly. So we really need a cardiology-centered medical home in addition to patient-centered medical. And then the nephrologists say, oh, gee, well, or the endocrinologists say, well, they don't really treat diabetes. You get the picture, right? So again, it seems like a good idea, but trying to figure out who's responsible and what's clinically relevant and how do I make my best decisions. There are methods and tools and technologies that are just becoming available today. And that's really what I want to talk about next. But does that make sense so far? Does anybody have any questions? I know I've been talking for a while, but does that, any questions so far?
I think Simran has a question.
Sure.
Yeah. Hi, my name is Simran. Thank you so much for like talking and things like that. So I sort of like, and like, I feel like we talk about for electronic health records, I feel like we talk a lot about like Taiwan, like them being like the holy grail of like smart cards, right? Everyone gets a smart card. They have their electronic health record on it. They go see their doctor, they put it in, they put their little chip in, and then pulls up their electronic health record, right? And Taiwan basically has almost 20 million people on this system. Mind you, they do have like a single payer system over there, but why do you feel like a technology like that worked there for like 20 million people, and why do you feel like that would never work out here? Because it feels really intuitive, right, to have like a universal electronic health record or have some sort of that. It feels very intuitive, but like, why do you feel like it's taken this long and for us to not even get anywhere near that?
Well, let me talk about your card thing that you mentioned, and please, I am not picking on you at all, so I don't. But when I was in college, what I would do is I would give my ID to my buddy to get into college, so he could use my card to get in. So first of all, there's an issue with, is it your card? Now, let's say we resolve that issue because there's biometrics and you could do two-factor authentication and everything else. Now, I knock you unconscious. And while I knock you unconscious, your card gets sent out someplace else or scattered out on the road. You get boarded unconscious without your card. What do you do? I'm not trying to blow it apart. I think there are answers to this, but I mean, any solution that's out there, there are reasons why there's an Achilles heel to it and an argument against it. And in the United States, I think you also, there's a couple of things. So first of all, let me put those two things out there, but then let me also bring it back in Taiwan versus here. Reimbursement in the healthcare system, unless you're in a Kaiser environment where it's single payer and your doctors know who you are, there's going to be first of all, how do you get paid? Am I participating? And what if I don't participate? When I say participating, do I agree with the insurance company? Are they paying the same amount that I charge for what I do? So what I mean by that is, and again, I don't want to get too esoteric on this, but you're probably too young, but you probably know somebody who has cancer, right? If you knew somebody who ever had cancer and you live in the United States, would you want to go, depending on where you live, would you want to go to the hospital that's closest to you, or would you rather go to Memorial Sloan Kettering or MD Anderson, or Cedars-Sinai, depending on where you live in the country? How many people do you think would say, I don't care which hospital I go to, I get treated the same everywhere? Not many. Everybody says, I need to go to the best and the brightest and everything else. And in those cases, they may charge a different amount or a different premium. They may not be participating in that. If it's single payer and everybody gets paid, I agree that that is a solution and it could work that way. And then it's just a matter of allocation of resources. But then we would get into what happens in the UK and also, quite frankly, in Canada and in India, as a matter of fact, where you have excellent healthcare that's available to you, but it's allocated by actuary table. So you get triaged, and based on your outcome numbers in a book determines when you get your MRI or when you get your treatment. So some people may die waiting to get an MRI in some of those countries. So again, there's always reasons why a particular system won't work in the United States. I happen to agree with you. I think that we do need to move to a single payer solution. I think again, oh, Jesus Christ, I'm probably going to be shot. And you're recording this too. I think that having a single payer solution or having Medicare for all makes a lot of sense. If we were to pay our premiums through our employers into a Medicare type system, I think there would be enough money and an ability to adjudicate and do things Medicare for all, which would be close of an analog to single payer system. I've alienated every Republican who's in this class. I don't know how many there are, but every single one of you is like, you idiot. You have no idea you're going to bankrupt us in 2 years. I just don't know how much more tenable our current system is, where who you are and how much money you have determines the quality of care that you get, right? So even with insurance, and I even said it about myself, I make enough money where I can pay to have a concierge medical practice. If I call my doc after this call, if I have chest pain from this call, I call my doctor, she'll answer the phone, right? I have her cell phone number and I pay for that. And I mean, that's not fair to my son who's 18 years old, who is just starting his life. He can't do that. He has to go and call his pediatrician between 9 and 5 or 9 and 2, whenever the hell she works. But I have different choices because the amount of money that I make and what I do is different from other people. So does that answer your question, or did I ramble around too much?
No, it did. Yeah, a little bit.
Did I, what, is there anything that you disagree with, or you want me to focus
No,
more?
I
spend
definitely,
hours on that.
agree. I feel like people in the US, I feel like it becomes a privacy issue. Like, the question that you were posing, sort of like, if someone steals your card, what happens, right? Like, what happens when someone steals your credit card, right? Like,
Well, I didn't say steal. I said
or
borrow.
like, okay, if someone.
It's a big difference. It's like stealing a card versus lending a card. It's a lot harder to catch that, right?
Right. No, you're absolutely right in that regard. But yeah, like you hit on all the points. So
yeah, and I mean, if you lose your card, or if you're unconscious and you can't say it's your card, and I agree with you. I think there are some benefits to that, and I think there are ways to do it. Actually, we have something very similar, and let's talk about some of the because we've talked a little bit about it. Oh, by the way, any other questions so far before I talk about some of the tools? Any other ones?
Yes. Well, hi, thank you so much for coming today. So I don't know, I'm just sort of, at this point, I'm just sort of frustrated with like how many different healthcare systems there are in the US. And I guess like how communication is it's just so slow. So my question is like, how faulty is the system? And then like, how have we been able to like, I guess, survive so long with just so many different systems trying to communicate with each other with constant updates and like in code and everything like that?
Yeah, that's a great question. Another great question. So how have we been able to survive this far? Well, not well. I mean, what's the current statistic? There are 100,000 deaths per year from medical errors alone. So we're not. I would submit that we're probably not doing as well as we could. I mean, there are checks and balances, and there are some ways to communicate that. Medications in particular, the DEA in the United States, the Drug Enforcement Agency, started this, but there's actually every state except for Minnesota, believe it or not. I don't know why I'm telling you that everybody's going to move to Minnesota. Has a controlled substances solution. So basically what that means is that when let's say I have a drug like oxycodone or fentanyl, or a prescription for fentanyl, whatever it is, and I go to fill it, that goes into a database, and that database is checked against when's the last time you filled it. So you have to do 2-factor authentication. There has to be triplicates of the actual prescription, and it is checked against database to make sure you're not filling it from multiple places. And every place but Minnesota will check against the other states. Now, when I say other states, usually other states touching them. So I could go between New Jersey and California, and they would never talk to one another. But there is a method. There's something called an HIE, or a health information exchange, where I can demand it. I can actually say today, I can say, they'll say, where are you from? I'll say, I'm from New Jersey. Well, they'll go onto their electronic medical record at Kaiser, and they'll say, give me his medical record from New Jersey. And they'll find my medical record at some non-federated or some system out there that's also connected to, when I say HIE, a health information exchange. A health information exchange is essentially a big network that allows electronic medical record and billing and prescription information to be shared, right? So I can demand that record, even though it's not the same location or it's not touching, I can demand my record from someplace else and share that information. So that's one of the ways we've been able to limp along doing that. But right now it's a manual process, and any manual process that has a human being in it is a point of failure. And that's where there are some very exciting things that are happening today that are starting to move away, or not so much move away, but supplement human interaction, right? Because human interaction, that's the Achilles heel. When I say that's the Achilles heel, anytime there's a person in the center of a process, mistakes are going to happen. I don't care how smart you are. I don't care what school you go to. I know I got some of you go to Brown. I got some of you go to Berkeley. I got, very smart. I guarantee you, you have good days and bad days. I guarantee you that there is going to be a day where you'll make a mistake. If you don't, everybody does. So that human element in the healthcare system is the point of failure. Now, there are some solutions. There's a concept called robotic process automation, or RPA. And RPA, in my opinion, is one of the groundbreaking technologies that is just in its infancy today, but in reality, over the next 10 to 15 years, in my opinion, robotic process automation, as it grows into the healthcare system and obtains healthcare level certification. What I mean by that is that one of the groups, my background, I sat on a committee called CCHIT. I rubber stamped electronic medical records. My job was when an electronic medical record vendor writes a women's health electronic medical record, I sat on the work group that said, what does that mean? What does it mean to have a women's health record, and what components need to be in it? So first way is you set legislation where you put rules and regulations, okay, and those rules and regulations have to be followed. Robotic process automation essentially is a way to have a robot, a software robot, check those rules and make sure that they're being followed. It's a way to automate any task. So reading of a record, do you remember what I said about my records pre-2015, where I had ICD-9 codes? Well, now that we've moved to ICD-10, I have records that are 100 years old that are typed out in a paper chart. And historically, up until now, I would have to read those charts. There's people at the American Cancer Society, their job is called an abstractor. And an abstractor's job is a clinician to read a chart and manually pull out staging information, diagnosis information, any information about the tumor. It's a manual process. I can actually make a robot using natural language processing that can read a document and pull out detail and take a record that was typewritten or handwritten, there's some that are even handwritten today, from 100 years ago, and extract the detail out for that left hip. So I can translate my records that don't say left hip on my claim form. It can read my old records from 10 years ago or 15 years ago or 30 years ago and translate that using natural language processing into codified detail for ICD-10 codes. So if I can just take a robot to go read all my PDFs in a hospital and bring all the codification or all the detail for each one. So each one of these, CPT, that's a code type. That's a data point. ICD, that's a data point. NDC is a data point. HCPCS, that's the drugs that they hang in the hospital. That's a data point. SNOMED is a language that's actually a data dictionary. Risk packs. So if I want to see an ejection fraction of less than 40%, which is a heart thing when you're doing a heart echo and you're squeezing out blood, you want to see the percentage of blood that gets ejected. It's called the ejection fraction. So that's a data point, right? My documentation of my records, I can actually have a robot using natural language processing and a fire engine, not a fire engine like the red sirens, but FHIR, Fast Healthcare Interoperability Record, take that information and share it automatically. So I can actually communicate and automate this process using a robot. And when I use robotic process automation, if I don't trust it, there are two types of robotic process automation. There's what's called attended and unattended. Attended automation still has a human in the loop. So rather than that human reading through 500 pages of notes, I just have to read through the data points. It actually shrinks it to less than 10% of what they were reading before, and they can accept or reject. That's attended automation. That's an interim step until you fully trust it. Then you can go to unattended where it just does it all day long, right? So that's one technology. And that's, if I were you, regardless of what field you go into, my advice would be for you to investigate RPA, or robotic process automation, because there are companies that can train you for free today. UiPath, although UiPath doesn't have a healthcare vertical and they're not what they call high trust certified, which is a healthcare specific automation requirement, they're actually pretty good, and they can train you on the basics and actually really advanced how to do RPA. Automation Anywhere is another vendor that does RPA, and they are high trust certified. So Automation Anywhere is a good one that I would learn. They don't really do too well with attended automation. But back to RPA as well, in addition to reading documents, the risk packs thing, right now, there was an article in India. There's a product that was released 2 days ago called QXR. And what QXR does is it uses machine learning algorithms and robotic process automation to scan risk packs images. And what it does, if somebody has, let's talk about COVID, like we can get away without talking about COVID. Somebody who has COVID, if you look at their chest x-ray, you can see it looks like ground glass on their chest x-ray, very distinctive. Or if I have asbestosis, I'll see that the walls of my lungs will be thickened. You'll have thickened areas on the sides of your lungs, very characteristic of asbestosis. Or if I have pneumonia, I may have something called atelectasis, or I may have blunted costophrenic angles. Costophrenic angles are the points. When you look at a chest x-ray, you'll see, and Francis he's sweating with all this clinical stuff that's going on. But the costophrenic angles come down to a point. If they're blunted costophrenic angles, these are very easy to see. And you can train an orangutan to read a chest x-ray. So if I can actually go through and have a robot do it, so now if I'm a radiologist and I have 1,000 images of chest x-rays to go through, wouldn't it be easier if I still have 1,000 records to go through today, if I had a robot to go through and say, here of the 500 x-rays, here are the 25 that are interesting, which have blunted costophrenic angles, ground glass, thickening of the costophrenic angle, blunted costophrenic angles, whatever it is. Now my list is ranked in an order that makes sense, and all the stuff that's normal is left for the end. But when I'm fresh and when I'm starting, that stuff is brought up to the top. That is a tremendous benefit, and that kind of stuff, RPA and machine learning algorithms can do that stuff, and that's what's in its infancy having it. So this QXR, this company in India, released that, and they actually have released this machine learning algorithm for COVID. It actually is looking at COVID images across several of the locations or several areas in India, the provinces. The word is not province, but it's the different sections like Kerala and other areas like Mumbai. But it's actually reading risk packs images and telling you the interesting ones and putting them up top. So That is, in my opinion, and again, those are two examples. I can actually on and on and on. If I'm a data scientist and I'm doing covariate analysis, and let's say I want to assemble a Kaplan-Meier curve. Again, I don't know if any of you are in statistics or you've done this. If you are, you're probably, you're like, oh my God, I know what a Kaplan-Meier curve is. Even if you don't, doesn't matter. You can build a robot that can do the covariate extraction for that. So instead of finding it yourself and having to manually figure this stuff out, you can set up robots to do that. And again, I don't make it, I don't work for any RPA vendor. I don't, but I can tell you the big three are UiPath, although they don't have a healthcare specific vertical. Automation Anywhere does have a healthcare specific vertical. And another company called Blue Prism has a healthcare vertical as well. The only one that's certified for healthcare is Automation Anywhere. There are other niche players, but those are the big three. And my advice, because it's not just the things that I'm mentioning, but also data science, covariate analysis, putting stuff into Python or R, or any other programming language, you can make your life a lot easier. And that's one of the things that I think if you take nothing else out of this, taking the human out of that first slide. Let me go back up to that stupid slide here. Hold on. Here we go. Paper, who cares about that? Let me go back up to the others. Hold on. Go back here. So back to this. Combining procedures and diagnosis codes in ways that maximize reimbursement. Back to this. Finding those procedures and diagnoses. Using robotic process automation to find those procedures and diagnoses in a historical record. And figuring out, and also when I say maximizing reimbursement, comparing that over time. So what else can you use robotic process automation for? So supply chains, those, I don't know how much you've been following at my age, or at Francis and my age, we follow the news about the new COVID vaccines, and the one vaccine that has to be at minus 94 degrees Fahrenheit the entire time when it's under shipment. That's the Pfizer vaccine. That's a pain in the ass. And knowing how to do that, or having a supply chain method, or finding out where COVID tests are being consumed most rapidly, you can actually look at data systems, big data, or having to analyze big data, like called claim system. You can actually look at when a clearinghouse or a health information exchange gets claims for COVID testing. There are codes U0001 and U07.1, which is a diagnosis code for confirmed COVID. You can figure out where COVID tests are being consumed the fastest in real time. These databases are available today, usually with 24 hours notice. So you can actually use robotic process automation in a supply chain and figure out where to send the COVID vaccine, because it's so expensive to send it in that minus 94 degrees Fahrenheit the entire time. You don't want to make a mistake. You don't want to send it to someplace where it's going to be sitting for 2 weeks. So using robotic process automation and looking at open claims databases where you're seeing how consumable tests are being done with positive results will give you an idea of where to ship things and where to spend your money. Again, we could spend the entire time talking just about that. Any questions on that? Or, I mean, I could keep going on and on and on, but I think those are the areas where I think it's important. But I want to open it up and hear more from you guys, because I feel like you're not getting that much out of this other than listening to me.
I have a quick question, basically writing on the whole robotics. And actually it's going to be basically about the future of healthcare, but I also want to like piggyback this on another question that one of our students here has just direct message to me. But essentially, like, potentially how this could look in the next 30 to 40 years in terms of robotics, and how that impacts, especially the people here who are pre-med or any kind of health engagement bed, especially the ones who are potentially going to be providers. In the next 30 to 40 years, that's potentially their entire career right there, right? And if robotics are exponentially becoming more and more prevalent in the decision-making process, which I already see right now in actual practicality. Michelle, are you there? Michelle, say hi.
Yeah, I'm
You
here.
want to ask your question? Mine essentially piggyback, but can you want to ask your question to Stella? Essentially, that's going to be very much attuned to what I just kind of posed there.
Sure. Well, my thought is like, if there's two things we know about Americans, it's that they love lawsuits, so medical malpractice, and that they don't particularly trust technology. They would prefer to interact with other people, and that's kind of like the general state of where things are. I'm intrigued to hear. I'm really interested in bioethics, so kind of the bioethical implications of things like RPA. Who do we hold accountable for misrepresentation of data? Is it, you know, like if things were to go wrong, and as you talk about going further and further into diagnoses, right? Robots being involved in that, what is, humans are trying to double check each other, and we'll use currently robots to double check ourselves. But what is kind of the check on that kind of power that we're giving to technology?
That's another great question. That's why I love doing this for Francis, because you guys, you go right for the jugular. So it's great. No, I mean, it's fantastic. So, and that's why I actually presented it the way I did, and I hid it in what I was saying. So there's two types of automation: attended automation and unattended automation. And attended automation, first of all, let's talk about that. Attended automation might also be called human in the loop automation. That's where we are today, and that's, to your point, and to the radiologist. Let's stick with the radiologist. So if I'm a radiologist, when I come into my desk, I come in the morning, I have 500 images that I have to review. Okay, let's call them chest x-rays. I'd say I have 500 chest x-rays that I have to review. Right now, they're in the order that they came in. That's what they're in. If I use RPA, I don't use RPA to diagnose. What I use RPA to do, I use an attended automation robot to scan all 500 records and reorder the list. So basically, I bring the interesting x-rays to the top of the list and leave the ones that appear to be normal at the bottom. But the decision-making process is still in the hands of the radiologist. So that is, to your point, no one would allow a robot today to automatically diagnose a normal x-ray and send it. The radiologist still has to click and verify and do their job. Robotic process automation, using attended automation, keeping a human in the loop, allows that responsibility to still be maintained by the clinician, just as it is today. The difference is that I'm more focused. So it's a job that allows me to focus more. So that, and that's why I mentioned the different vendors, right? So UiPath currently is the only vendor that offers attended automation. Automation Anywhere, good, bad, or indifferent, all they offer is the other type of automation, which is unattended automation. The problem with unattended automation is that it would make all those decisions for you. So that's why I mentioned you need to look at all three of them, but keeping that attended automation, I think we need to make sure that for the time being, when you're implementing a robot, any automation strategy, that you have checkpoints and you build a process document of where a human needs to intervene. And we see that whenever we implement robotic process automation in any healthcare or life science setting, anywhere a smart person sits, even though they're also the point of failure if they're doing it themselves, the reason that people fail, remember what I said earlier, somebody has a bad day. On your best day, you're not going to make a mistake, but on a bad day, you might make a mistake. Okay. I want the smart people to not have the decisions taken away from them. What I want to do is I want to focus them so that when they're fresh, they're making the best decisions they can. And then the rest of the ones that who care, you know, you can pay quote unquote less attention to, you can look at those later. Does that help a little bit at all? Answer that question, Michelle?
Yeah, definitely. Yeah.
Okay. But I think you're right. In the future, having that decision about, and Francis, to your question about 30 to 40 years, the reality is, I don't think there's, as you know, as soon as you go beyond 5 years, any of the things that we're guessing at, we're guessing. I mean, the reality is that stuff changes all the time. I think one of the things that will exist in 30 years is we need to get unstructured documentation and unstructured historical information that needs to be structured. And I think that regardless of what happens, I think it's pretty safe to say that there will continually be advancements in technology that codifies or structures unstructured documentation. So what I mean by that is looking at that written record or that handwritten record or the typewritten record and pulling out so let's talk about COVID, right? So COVID, as any virologists here, anybody studying virology? Do we know any or no? Any of your students studying virology?
I'm studying infectious disease.
Okay, so all right. So when I say the coronavirus, there were two previous coronavirus, not pandemics, but epidemics that happened over the past 10 years. One was MERS and one was SARS. And one of them was an upper respiratory, basically when you looked at the coronavirus that affected, one was an upper respiratory infection and one was a lower respiratory infection. COVID-19 is both upper and lower respiratory infection. So it actually was the best or worst of both worlds. The thing about an upper respiratory infection virus like the SARS one is that very easy to transmit from person to person. Also very fragile, happens to break a lot. The lower respiratory one like MERS, a lot harder to transmit from person to person. Also a lot harder to treat. Now, COVID-19 had the best of those. It was both upper and lower respiratory, but there's tremendous value in what we learned from fighting MERS and what we learned from fighting SARS. So when all of a sudden, what I do today is I work with data sources that have 14 years or 15 years of clinical data in claims data or electronic medical record data as well. And we had a flood of Pfizer's and Moderna's and Sanofi's and Eli Lilly's who came in and said, give me all of the data that you had for SARS and MERS and show me outcomes. And let's do what they call signal detection or pharmacovigilance, where you look at, are there any things that we saw in those patients with SARS and MERS that are common in a statistically significant way? So you can run for your infectious disease algorithms, you can run and look and say, for both MERS and SARS, was there a common theme or was there something that happened in their history that had more of a propensity for them to develop a more serious disease? That's how we learned about cytokine storms and everything else. But by looking at those old diseases or those two different types of coronaviruses, we were able to learn a lot. And as a result, we're able to get a vaccine and a treatment much faster to market because we're able to look at that historical data. That is a perfect example of using older data in a novel way. And I mean, if you were a virologist or you do an infectious disease, you know, up until this vaccine, there were three types of vaccine: attenuated, toxoid, and killed. Right now, there's mRNA as well, but that was it. And attenuated, toxoid, and killed vaccines took 10 years to develop, at a minimum 10 years to develop. So we did this one in less than 6 months. And the way that we're able to do that is big data, is looking at different data sources, looking for things like, when I say pharmacovigilance, I mean looking for signals, looking for things that happen in a big data source that happens more often than just once or twice. This is something Francis and I have talked about. There's something called biosurveillance. I don't know, probably none of you remember this, but Francis and I are old enough to remember when anthrax was mailed in the mail. There was a story that came out. There was a dude who went to a walk-in clinic about 6 miles up the road from me here in Red Bank, and he had a blue rash and a hacking cough. And if they had an electronic medical record in there with a biosurveillance program in it, those two symptoms, blue rash and a hacking cough, 96.77 something percent of the time, the reason you would have a blue rash and a hacking cough is exposure to inhalation anthrax. They would have known that in real time. So in most electronic medical records today, there's a biosurveillance tool that's put in by the NSA that actually monitors. That's why I use XML in a lot of continuity of care documents, because you have the ability to ping that from an external source. So a lot of people don't know that that's in there, but these types of things, or these new use cases that you hadn't thought of in the past, I can use in the future. So COVID, I can use it to look for what worked in the past for 2 separate diseases, because this new disease is a combination of those. But let me look at those others, and what I learned from those other diseases, does that help me today? It absolutely did. Or I can use it for bioterrorism and biosurveillance to make sure that nobody else mails anthrax. And again, 2 examples among dozens. Make sense? Anybody else? Any other? Oh, I see there was a cat who came in to visit. I saw that for a second.
Yes,
What other? I mean, any other questions? I mean, I keep you here all night. I mean, I don't know what time it is, or geez, we're running out of time.
Any more questions from anybody?
I have a question that's like going back kind of to what we were talking about earlier with the electronic medical records.
Sure.
If there were to be any sort of like more universal record that would allow providers to communicate and collaborate more, I feel like one of the biggest challenges is that providers like often don't like to change the way that they do things, and to like make everybody restart a system that's all universal would seem like a really big challenge in getting providers to be willing to do that. How do you think that you would best be able to combat that issue?
That's a great question as well. Actually, that's probably the first good question I've gotten. Are there any other questions? No, I'm kidding. Yeah, I mean, I would always say with electronic medical records, it's like herding cats into a blender. Sorry, my cat lovers, but you just, I mean, I had a doctor tell me, son, eagles don't fly in formation, when we were talking about electronic medical records. I said, yeah, but they're also on the endangered species list. You're probably going to die alone. But you're right. The bottom line is doctors typically don't want to do things all at once. So you have to do a couple of things, which we did a pretty good job of. You incentivize them. It's either a carrot or a stick, right? What I mean by that is you either give them money to adopt technology, which we did. We actually, MACRA and MIPS and alternative payment models are the current ones. But there was a program under CCHIT that came out that was essentially meaningful use. You had to show you were using an electronic medical record meaningfully. And if you did that, you got XY amount of money from the federal government. I think and that's the carrot. The stick was, if you don't do this, or you don't submit all your Medicare patients to us electronically to look over whatever it is you're doing, by this date, we're going to cut your reimbursement. So it's with money. And again, I left this slide up for a reason. See those last 2 words, maximizes reimbursement? Right there. That's the only way you're going to get doctors to do anything, is to mess with their money. And you either give them more money as a carrot, or you take it away as a stick. Or you don't or you take away choices, right? So Athena Health, an electronic medical record that's out here in the United States, they are the platinum standard when it comes, Kaiser Health is the platinum standard when it comes to cleanliness of records, because it's the same system that Kaiser, it's all one system. Athena Health is the gold standard. It's the next best thing, because Athena Health requires that doctors all do the same thing. So when I'm a cardiologist and I come in to Athena Health and I say, I don't like the way this template is set up, I do my exams this way. Athena Health says, too bad, do it this way, or you're not a customer for us. And they make the doctors adopt their way of doing things, and they hate it, and they kick and scream, and they hate it. Adoption goes really low. They have to hire scribes. So that's why it's taking so long, is because the only tools that we have available to us are the carrot and the stick. And because there are different payers, I can participate with those insurance companies that reward my behavior, and I can not participate with those who challenge or punish my behavior. So that's why you may go to a doctor and say, I don't participate in Aetna, because Aetna doesn't pay me, but Cigna does. So they'll participate with Cigna, but not Aetna. So that's why this whole concept of getting into a single payer solution, where if it's just one, if it was just Medicare, the federal government, take it or leave it. And if you don't like it, go to private medicine or concierge, where people are going to pay for it out of pocket. But the only way you're going to get doctors to comply are with these last two, or this last word, reimbursement. In my Francis, do you agree or do you disagree? Francis?
Yeah, 100% agree. Like basically when we were doing healthcare tech, it came down to two things. The question, and these are doctors. These are doctors that had their own offices in hospitals. Is this going to make me money or save me money? That's all they cared about. The word patient never came in that sentence in discussion at all. It was, am I going to make money from this, or is this going to save me more money? That really came down to every conversation I ever had with them.
That's right. Every conversation. And then after that question is, how many clicks do I have to do? How much time is it going to take? Does it save me time or add time to my day? Which again, goes back to reimbursement. It's back to, that's why I say there's a very cynical sentence, but it's actually the truest sentence that I've found. What else? Anybody else?
Hi, I have a question. It sounds like this is a pretty accurate definition of healthcare, but I'm sort of wondering if it has the potential to change. I mean, the profitability of healthcare and the industry can almost, it pretty much leads to unethical, inequitable quality of care. So for someone like myself who's really interested in like health policy and building health equity and providing care to underserved populations, do you think like this is more of a zero-sum game, or like how do we get back to this like real patient-centered care?
Kareem, Kareem, you're a resident Canadian, right?
I am, yeah. I was the Canadian Francis was talking about.
Okay, nice to meet you online. But yeah, which province or where are you?
I'm currently in Toronto.
Okay,
Ontario.
all right. So you're on the west, so you're by British Columbia.
More southeast.
South. Okay.
Yeah.
Oh, sorry. It's a long time since I've been there.
Yeah, the other side. I think he's neighbors with you, actually.
Both cold. It's still pretty cold in both areas. So
that's true. Yeah. As a matter of fact, well, I mean, I was at a healthcare conference. You ever saw the movie Whip It, which was about roller derby? I was in that. I was actually one of the referee skaters. They were filming it at the time, and I'm a ref roller. Anyway, whatever. Stupid. So yeah, I'll tell you, it's the biggest struggle. I don't think it's a zero-sum game, to answer your question. I think today we are really struggling for because we see there are tremendous disparities in medicine. And I'll tell you, one of the things which wasn't true 2 years ago, but is very true today. People are starting, when I say not even people, governmental organizations and life science organizations. When I say life sciences, like Pfizer's and drug companies, Food and Drug Administration, Centers for Disease Control, they are now starting to look at not just what they call feasibility counts to do studies. When you want to do a study on something, you figure out how feasible is it to do, and you look at the number of patients that are available with a certain disorder. They've started to look at underserved populations by looking at urban versus rural patients. They're also looking at ethnographic studies as well. Even 2 years ago, if you said, give me feasibility count by a race ethnicity, couldn't do it. I mean, as a matter of fact, today you can barely do it. There's a company called the Novolon that I work for, Avalier, that actually does capture Medicaid data and CMS Medicaid data, which because of COVID is becoming more and more relevant because people are losing their jobs or they're losing their health benefits. And because they're losing health benefits, they're having to go on state aid, which is Medicaid and Medicare. We're finding that Medicaid, because ethnicity is a required field, we are able to start to provide data ethnically, which is actually, again, the biggest way that I think we're going to do. We're going to actually change this and make outcomes better across different socioeconomic and different types of patients by looking at urban versus rural, by looking at disease progression, by across ethnic lines. And is it the same for Asian versus white versus Black versus Latino? All of that stuff is happening today. And again, this is brand new stuff. When I say brand new, as I said, 2 years ago, nobody was asking, nobody cared. No, I mean, they might've cared, but it wasn't even a question that was even formulated. Now, of the phone calls that I get on a weekly basis, I would say 98% of them are looking for that information, either connected the data to not just ZIP3. When I say ZIP3, patient de-identified data has to be de-identified, so you can't re-identify the patient. So they typically only do 3-digit zip code identification. So they're connecting that to urban versus rural locations. And then also ethnicity is required on CMS-based claims. So we're actually getting counts run by, I did a count today for asthma, and another one for breast cancer, and another one for COVID and prostate cancer by ethnicity. So I think that we're just starting to understand. First of all, we understand there's a problem, and I think it's fixable, and we are really struggling to fix that problem. But I can tell you it's a huge gap today. We have a lot of catch up to do. I mean, Francis, how do you feel about, what do you see out there? I mean, is there anybody you know that does it really well, that does ethnicity or urban rural or ethnographic, or have I said anything that you disagree with?
No, not yet. Like right now, I think you're right. We're like barely able to kind of, I think only recently because both political reasons and technology enablements have allowed us to start looking at that. But you're right, in just 10, 15 years ago, there wasn't enough motivation and momentum for that to be an issue. And if you don't have momentum, if it's not a political or financial or some sort of a market again, it's financial, then there's not going to be enough momentum to make it happen. But I think there's definitely enough political and financial incentive now for that to become something that people are now focusing their technologies onto. But you're absolutely right. Like we're finding a point right now where that is within our grasp, barely.
And it's just starting.
Yeah, just starting. And that's why data scientists are going to have a field day in the next so many years, because
honestly,
it's just like a harvest, a rich harvest for all of them. Every year just gets more and more data from the harvest.
Yeah.
My follow-up question would be,
please,
how long does it take for data to translate into actual effective policy changes?
Oh
God,
you're killing me.
I'll let you answer that one. I'm not gonna.
Look, he put his phone right on mute. See that? Went right onto mute for that. Oh my God. Wow. Unfortunately, that is actually the first good question that I've gotten. I don't have a good answer for that. I can tell you it depends on a couple of things. I would say, and it's going to be a very cynical answer. If the money's there, if there's a clear financial case, I can tell you things move pretty quickly. Politically, I mean, yes, things move, but they don't move nearly as quickly. I can tell you right now, everybody's scrambling and there's money available. NIH has actually released a whole bunch of grants to study this very thing. They've actually released about $75 million, which is not a lot of money. I mean, it may seem like a lot of money, but it's actually really an insulting amount of money to study this. But what they're finding is that you actually have to link to other data sources. And tokenization, that's another thing, data science, but tokenizing data, connecting one data source to another data source. Even 2 years ago, the big thing was genomics, right? So I almost cursed again. Nobody cared about breast cancer. They all wanted triple negative breast cancer, right? Which is a certain type of breast cancer. Now they want triple negative breast cancer by ethnicity. And they're being, drug companies are being reimbursed to make sure that their clinical trials are ethically diverse. So that money is there today. And I think we'll find that over the next 2 years. I don't think it's going to happen any faster than that, but I would say within the next 2 years, I think you'll see a significant uptick in the amount of reporting across ethnic lines and also urban versus rural as one. I think you're going to see that, and also type of insurance. That's another one. So the state aid ones, the CMS-based Medicaid, claims. Historically, you only had access to what they published on a yearly basis, which is actually 2 years old. So having access to data sources that are more current than that is just starting to happen now. So I would say in the best case scenario, the best way I can answer, if you hold my feet to the fire, I would say within 2 years, we would see some statistically significant changes in a positive way. To on the long side, never. I mean, shoot, we've been waiting for true interoperability since 2004, right? Or so, and we're still not.
Yeah, for as long as I've known you, we've been waiting for it.
Yeah. We're closer, but we're not there. And it's just because the money's not there. Like there's no, who's going to pay for it? Who's going to be responsible? Who's going to manage it? All these questions need to be answered. And I think I think because we've seen some horrible things happen, starting with Vioxx in the mid 90s, Vioxx came out. And that was the first time that we saw there were racial disparities in outcome. And that was our first bell, our first wake up bell, and we ignored it. And now I think we're paying that price, but I'm seeing the question being asked and being reimbursed more often by the by National Institutes for Health, by Centers for Disease Control and FDA, and the types of data they're looking at. So I think with that new focus and that intense focus, again, 2 years to never is the best I can give you.
I have a question in terms of the, I guess, incentives. I believe the U.S. government and other governments or organizations have incentives for research and development of compounds and treatments for some of these rare diseases, or for diseases and conditions that only affect minority populations. Is that the case, or am I missing?
Yeah, rare and orphan diseases. No. Yeah, there's another big component of what I do is I run feasibility counts for rare and orphan diseases as well, because there's a significant amount of reimbursement for those as well. Does that translate to policy is really the question that I don't see. I see right now there are emerging biopharma and other companies that are working on rare and orphan diseases, which typically do affect different historical patient populations. But again, it's the question. While there's money for that, I don't see that translating into policy, because rare and orphan diseases often, while they make the company a lot of money, you can't really make a lot of policy based on those, because again, it's just not enough. Hemophilia, perfect example, right? So hemophilia only affects about 20,000 people in the United States. There's only 200,000 people in the past 10 years that have had it worldwide. There's only about 20,000 in the United States today. You're just not going to get a policy written about that, regardless of what the ethnicity tells you.
Got it. Thank you.
I know it's a cynical way. Boy, really a way to bring this class down to a grinding halt. I've crashed the plane into the mountain. What else? Anybody else?
We got about 10 minutes, so who else has some last minute questions for Stelle before we close up the class in 10 minutes? Anyone else?
I mean, I keep going. I can talk about other stuff, but I figure I can give you your 10 minutes back.
Simran?
That's okay.
I have a question.
Yeah, sure.
Yeah, I had a question. So like 25%, like studies are coming out now saying that like roughly 25 to 30%, like the actual numbers like debated, of like healthcare spending is just waste, right? Like $760 billion to like $900 billion of healthcare spending is just wasted money on administrative processes and things like that. But you won't find, you'll read, I'm like really interested in like health policy, and I like reading these like research studies and stuff. You won't find a single research study that talks about interventions for administrative processes and administrative complexity. Like no one writes about that on how do we combat it, right? So like I think a part of this class is, we're creating these final projects, and we're thinking about like what are sort of the problems that our generation has to solve, right? And when it comes to administrative complexity, do you feel like, what are sort of like the big burning things that you would want like young people or like my generation to sort of like really tackle that? Like, are there certain things that you feel like are just sucking money out of the healthcare system?
Yeah, that's a great question. Yeah, and so and this is, and I've discussed this, and actually it's funny because I mentioned at the very beginning of this call, revenue cycle, my expertise in revenue cycle or the financial aspect and the clinical aspect. That dichotomy is essentially still there. And when people in the healthcare industry think of healthcare, they're usually thinking of clinical. They're not thinking of revenue cycle. The reality is you can't have one without the other. And I think if I were to say what would I wish you guys would focus on or the future would focus on is the linking of those two things together. Because if you can link the revenue cycle and, so boy, I'm throwing this detail at you, but if you look at how physicians are paid electronically, they send out a claim and then they receive a remittance back from the insurance company. And that's the file structure. It's an EDI file structure. It's called an 835 and an 837. And 835 and 837, one represents the claim going out, which is what charges I billed, and that's the 837. The 835 that comes back is what did I get reimbursed. And right now they're viewed as two separate things, but in reality they're inextricably linked with also 270, 271 files, which is eligibility. So is the provider eligible to see the patient on a certain day? So again, let me not give you some specific, let me back up and give you the more generic answer to that. The linkage between revenue cycle and clinical systems, that instead of the way that they're growing, which is in two parallel tracks, if you were to help bridge those back together and make them really one thing, combining eligibility and reimbursement as well as what's being billed out, I think that that's going to solve a lot of these other problems, combining it also with ethnicity and some of the other things we're talking about. But really that patient-centered medical home of linking the financial aspect. So again, Max, that reimbursement piece, if you can tightly link that to the clinical system and have them not as two separate entities, but really as one complex entity that is dependent on each other, that's the area where I think we're not spending enough attention. I think nobody cares because medical billing is not sexy. It's not interesting. It's very simple, but it's actually Simplexity. It's a great book called Simplexity, and it talks about the elegance of complex systems. And I would say if I were to oversimplify and say what would it take, I think that that's where the issue is really in right now. Billing managers are completely separated from the clinical study. The only person who sits in the middle are the coders. I'm a certified coder. I worked my way through school as for both inpatient and outpatient coding. So my job was to bill, but it was also to hold the doctors accountable for the procedures that they actually did and then the diagnoses. But I think we're close in the inpatient environment. So in the hospital environment, there's infrastructure and setup where you actually are doing clinical document review and actually having natural language processing where you're codifying this unstructured documentation. But if you structure the clinical documentation, the structure that you create in the clinical documentation is what the revenue cycle stuff needs to feed that engine. So that's what I mean. If you codify that clinical stuff, it becomes the energy or the ATP or the wood fuel for the burning engine. Does that make sense? Is that too esoteric, or does that answer the question?
No, that absolutely answered the question. It's actually really interesting because I've never heard that answer. I feel like I've heard a lot more like very vague, generic answers like, oh, we need to redo like the EHR system. We need to redo.
I'll be here all week. Try the veal.
Yeah.
No, that's honestly. I mean, that's Francis has known me as long as Francis has known me. That's what I've said, and that's where I think we keep missing because there's no one. If you think about even corporate structure, right? So a hospital, what do you have? You have a CEO, a CMIO, a CMO, a CFO. They're in charge of verticals, right? There's nobody who's responsible for integration of that together, right? So that's why I think robotic process automation, stitching those things together and creating codified data from the clinical information that feeds the financial engine and then linking those together. And again, I weave this in, right? So natural language processing, machine learning, and being able to read a computer screen, that's robotic process automation. That codification creates ICD-9, ICD-10 codes, CPT codes, HCPCS, drug names that all can be used to bill that information out correctly and properly. And then once you have that information put into the system properly and historical information, it can help you with outcomes as well. And that information together, you can stitch it together into disparate systems using things like FHIR, which is fast healthcare interoperability, to have different healthcare systems to communicate with one another. So that's it, and it really is in that chasm of a space between revenue cycle and clinical.
Awesome. Thank you, Stelle. I only have a few minutes, but would you be okay sharing? Hopefully you're not putting in a spot, or sharing your contact or your email for anyone.
Sure, I think I had it on my last slide. It's my name, so I mean,
Awesome.
I'm easy to find. So it's, yeah, that's me. So you have my cell phone if you want to call me. There's it's my name, stellsmith@gmail. If you want to connect with me on LinkedIn, I'm happy to. I mean, Francis, I'll tell you. I mean, Jessica Ken. I talked to her last week. I met her many years ago at one of these in person in Berkeley. And I'm always happy to numb you to sleep with detail, and I can talk to you about what I found. And again, what do I know? I can also put you in contact with folks who are way smarter than I. I just lift heavy things. I make the big rocks into small rocks.
Yeah, so definitely keep in touch with Stelle if you guys can. Jessica met Stelle here many years ago when this class first started. Since then, she has gone through 3 different companies as now a data scientist in healthcare. And Stelle, thank you for giving her such a great recommendation, getting her most recent job right now. So Stelle is an amazing contact to have, you guys. Don't waste this opportunity.
Yeah.
First of all, thank you so much, Stelle.
You guys have a tremendous opportunity with Francis and Edge interns, and what you're doing or working with Francis. Again, let me tell you, I don't know if you recognize how big of an opportunity you have in working with Francis as well. The folks that he knows, you really do have more advantage in knowing him as well, in getting into really great company. I don't know about staying there, but at least getting you in the door, he can certainly get you in.
Yeah, can help out any way we can. So thank you again so much for everything, Stelle. And Carlos, did you say you have one announcement you want to make to everyone before we adjourn?
Yeah, I did have an announcement. Again, thank you so much, Stelle. I'm sure I definitely will. And then perhaps a lot of students will be in contact with you for more questions. Yeah, for the students, just so you know, we will be sending out a review of your feedback from your proposals later today. So keep an eye out on that. There will be no homework this week. The homework will basically be, I guess, personalized. So depending on the feedback that you get, we might ask for an update just to see, how to adjust, or if we think that your proposal was great and your idea for the final presentation is going perfect, then you can just have the rest of the week. So yeah, that'll be handled all on a personalized or on a team-by-team basis. So yeah, please keep an eye out for that.
Okay, great. Thank you so much. If there's nothing else, then I think we're done. I hope you guys have a wonderful and warm Thanksgiving. A happy Thanksgiving to wherever you guys are in the world. And I look forward to seeing you all next week. And Stelle, I hope to see you on December 7th when they're in the hot seat.
You got it. I'll be there. Thanks, guys. Thanks for your attention. It was really nice meeting all of you.
Thank you. Have a good night, everybody.
Bye-bye. Happy Thanksgiving, everyone.
Bye, guys.